Hello everyone, this is Group 1 and today we will be presenting about patient monitoring and control. So what is patient monitoring and control? This is about observing processes over time. And this ensures that these processes remain within safe boundaries or helps detect risky changes that might need intervention. So for example, at the individual level, we may monitor a patient's ECG if they are at risk for arrhythmias. And at the system level, we may track disease outbreaks or adverse events across hospitals. So this idea follows the model measure manage cycle.
Dynamic signals can vary in both time and frequency. When we measure a dynamic signal at different time points, the values vary and creates a waveform or a graph of the signal plotted over time. Most dynamic signals show periodicity, meaning they repeat in a regular cycle in an increasing and decreasing value. There are three main attributes of any time varying signals. No? First, we have the amplitude. This is the highest value that the signal reaches in a cycle. So as you can see sa kaning orange highlight, no, mao ning highest na ma-reach sa wave. Second, we have frequency. This refers to how long it takes to complete one full cycle. So kaning purple na highlight sa image. And third, the phase tells us the current state of the system at any point in time. Out of phase is when we compare two identical signals that repeat, but one is slightly delayed. So as seen on the second image, both signals have the same shape and frequency, but they don't start at the same time. Kaya nag-una si blue, kaya isa kang black wave, no? So phase is often measured by the degree of this time offset from the origin, which helps us understand how signals align or differ over time. To better understand dynamic signals, we use three different views, which will help give us a unique perspective on how the signal behaves. The first and most natural view is the time domain. This shows how the signal's value changes over time. So as shown in the first graph, it's like watching the signal move or fluctuate as time goes by. The second view is the frequency domain. Here we break a complex waveform into simpler sine waves, a process discovered by the famous French mathematician Fourier. This view shows us which frequencies make up the signal, like a fingerprint of the waveform but without showing the time or phase. To convert a waveform into a frequency domain, we use a mathematical process called the Fourier transform. So as shown sa second graph, we separate na niya ang complex waveform into two, no? Here po sa third graph, there's two frequency bands since two man pod ka waves. One band for the bigger wave and one band for the smaller wave. The third view is the phase portrait. This shows how the state of a system, like its position and speed, changes over repeated cycles. It's a view that doesn't depend on time or frequency. Let's take a frictionless pendulum as an example. In a time domain, its swing looks like a sine wave, no? Murag up and down lang siya sa graph. So in the frequency domain, it shows a single frequency band since one naman siya ka wave. But in the phase portrait, we graph its distance from the center and its velocity. So without friction, the phase portrait is a circle representing its continuous motion. Now if we add friction, or if there's friction, the pendulum slows down and comes to rest. In the phase portrait, the circle becomes a spiral, moving towards an attractor, which is the center point where the motion stops.
Statistical Process Control, or SPC, in patient monitoring. SPC uses historical data to establish what is considered normal for a time-varying signal. This means, for example, a patient's heart rate or blood pressure over time. It's important to understand that SPC is designed to tolerate natural variations, which are the normal ups and downs we see every day. The system only triggers alerts when a signal deviates significantly from this established normal, indicating a special cause. So SPC is not about predicting every change, but about flagging when something is truly out of the ordinary. In SPC, we differentiate between two types of variation: common and special cause. Common cause variation refers to the normal expected fluctuations that occur within a stable system. A patient's heart rate increasing during exercise is a perfect example. Special cause variation, on the other hand, indicates a new or significant event like a sudden drop in blood pressure due to internal bleeding or a device malfunction. Misclassifying these variations can lead to unnecessary interventions or missed critical events. SPC charts are visual tools that helps us monitor data in real time. These charts have upper and lower control limits, typically set at 3 standard deviations from the mean. As long as the data remains within these limits, the system is considered stable and in control. However, if a data point exceeds these limits, it triggers an alert suggesting a potential special cause that requires investigation. SPC can be applied to monitor a wide range of variables in healthcare. This includes physiological parameters like heart rate and blood pressure, instrument performance, patient health metrics such as fall rates and pain levels, clinical management processes, and even patient experience indicators. By monitoring these variables, we can proactively identify potential issues and improve overall healthcare delivery. SPC can be tailored to specific clinical needs.
Signal processing involves capturing, converting, and interpreting physiological data like ECG or blood pressure. It helps doctors and nurses make informed decisions and reduces errors in patient monitoring. The first step is signal acquisition using sensors, like ECG leads. Next, the signal is converted from analog to digital, then proceed to remove noise. Finally, the clean signal is interpreted for its clinical meaning. Since computers can only understand digital data, we convert the continuous signals into digital numbers using ADC. The more bits we use, the clearer the signal. Also, the signal must be sampled fast enough, at least twice its highest frequency, to avoid errors like aliasing. So here's an example of analog to digital conversion. Noise and artifacts are unwanted parts of a signal. For example, a patient moving can cause artifacts in ECG. We use filters like the Kalman filter or the Fourier transform to clean these signals, making sure they're reliable for clinical use. So here's an example. By analyzing the signal in the frequency domain, we can spot issues with the monitoring system itself. For instance, overdamping can flatten signals, making systolic blood pressure appear lower than it really is. Underdamping does the opposite, recognizing these helps in calibrating devices properly. Instead of relying on a simple high or low thresholds, modern systems interpret signals more intelligently. A good example is calculating stroke volume from the area under a pressure of a waveform, or looking at the QRS height changes in ECG to spot abnormalities. Instead of relying on a simple high or low thresholds, modern systems interpret signals more intelligently. A good example is calculating stroke volume from the area under a pressure of a waveform, or looking at the QRS height changes in ECG to spot abnormalities.
Let's now talk about the multiple features that can be extracted from a single channel to support behavioral interpretation. Once a signal is clean and free from errors, the next step is to understand whether it indicates a clinically important condition. But relying on simple thresholds like fixed normal ranges often doesn't work well, because what's normal can vary depending on the patient's current condition and their treatment. That's why smart alarms were introduced. Instead of just checking the values, they analyze waveform patterns to extract deeper information. For example, from a single channel like arterial pressure, we can calculate clinically useful measures like stroke volume by analyzing the area under the curve. The same goes for ECG signals. Changes in the QRS height, the presence or absence of P waves, and the regularity between beats can all point to a specific heart condition. To do this, systems uses two steps: pattern recognition to identify the key features in the signal, and then model-based tools like neural networks or support vector machines to assign clinical meanings. This allows for more accurate and patient-specific interpretations, going beyond what a simple threshold can offer.
Cross-channel interpretation. This concept involves bringing together multiple lines of evidence to improve our reasoning about the meanings of various signals we encounter in clinical settings. The importance of cross-channel information. This technique serves useful purposes at several levels. Firstly, it aids in artifact decision, helping us validate the accuracy of our signals. Secondly, a significant role in clinical diagnosis, where we rely on combined information. So for cross-correlation techniques, we have three key methods to consider. Same signal, different interpretation method. Measuring heart rates, we might encounter errors using a simple peak detection algorithm. In different physical source, same signal, it involves comparing different ECG leads to confirm changes observed on one lead. And lastly is different signals, which is an example of this is when a flat portion of an ECG trace does not necessarily indicate a systole. Cross-channel information is not only useful for validation but also for diagnosing conditions. Many clinical conditions can be differentiated by analyzing the temporal order of events in their natural history. In conclusion, this approach facilitates complex reasoning and significantly improves diagnostic accuracy. By integrating diverse signal data, we enhance our ability to make better clinical decisions.
Use of decision support with contextual data. Contextual patient data enhances signal interpretation in clinical settings. In some cases, even with data from multiple signal channels, the information may not be sufficient to draw clear conclusions. By linking patient monitoring systems to electronic health records, clinicians gain access to additional contextual information that helps clarify ambiguous patterns such as unclear events in ECG readings. This added context allows clinical decision support system to provide more accurate and complex diagnosis while also helping to rule out alternative explanations, ultimately supporting better informed clinical decisions.
So moving on to patient monitoring in different settings. So first is high dependency settings. So in this setting, it is typically found in ICUs and operating theaters. It is for critically ill patients needing constant monitoring and rapid interventions. So in this environment, it is characterized by high acuity and high vigilance care. They heavily rely on continuous and advanced monitoring technologies, often integrated with Anesthesia Information Management System, or AIMS, for comprehensive data integration and timely decision support. So next is low dependency settings. So in this setting, it includes step-down units, post-operative recovery areas, and general hospital wards. Here, patients are stable but still require observation for changes in condition. The emphasis is on cost-effective, scalable monitoring solutions, often involving the introduction of wearable and portable sensors to track vital signs like heart rates, temperature, and oxygen saturation. So monitoring in this setting support early detection and escalation without needing intensive resources. Lastly, home and ambulatory settings. So in this setting, it caters to patients with chronic conditions, the elderly, or those recovering at home. Monitoring here often involves telehealth and remote patient monitoring technologies. Sensors track various parameters like blood pressure, glucose levels, weight, and respiratory function. Activity monitors assess daily living and detect changes in mobility. Crucially, data is transmitted to healthcare providers for review, enabling timely interventions and supporting aging in place and chronic disease management.
So autonomous therapeutic devices or automated systems can deliver therapeutic interventions and titrate or adjust doses based on monitored parameters once they are appropriately set up. They also require access to physiological data or well-validated physiological models and computational reasoning capacity or high-fidelity measurement technology. The first human error that we'd like to address is that high cognitive load can lead to a failure to detect monitored events. This happens because we have limited cognitive resources such as memory, and that when this happens, we miss or misinterpret real-time monitored data. This is known as a condition of inattentional blindness or looking but not seeing. And there are a lot of major contributing mechanisms such as having an amount of information available in some monitoring systems that are greater than can be assimilated by an individual. Another source of human error that we have to consider is the variations in expertise, which is also often associated with variations in decision performance and the need for automated support. Now, it's important to understand that expertise may vary from person to person and So for the last human error, we have the automation bias, which occurs when a human incorrectly agrees with an incorrect guidance from a clinical decision support system. Now, it's also termed as automation-induced complacency, and there are two classifications. Errors of omission occur when users miss events because the system did not prompt, and errors of commission occur when users follow the decision despite contradictions with training and available indicators. In conclusion, as devices become more intelligent, there's also a greater need to be more understanding of the advantages and limitations of these devices. In fact, clinicians should still seek to understand the nature and in particular the type of mistakes that both humans and machine are prone to make.